Good evening. I'm Dr. Smarnika from IEP Digital Media team. I will be the host for today's webinar on Bppv and its therapeutic approach with the resource person Dr. Amit Tyagi and Dr. Amit Verma, being organized by IIP and IPWC Noida branch. It will be moderated by Dr. Nikki Tyagi. The Indian Association of Physiotherapists is the oldest and largest association representing physiotherapists in India since 1955. The IAP digital media team consists of a group of physiotherapists who handle Zoom platform, webinar live streaming, and IAP profiles on social media platforms like Facebook, Instagram, Twitter, LinkedIn, and YouTube. Follow IAP profiles on the social media to receive notifications for our events such as webinars, workshops, CMEs, conferences, health camps, and blood donation drives to know and also to know more about recent updates on physiotherapy. Subscribe to IAP YouTube channel for notifications of our live webinars. In the playlist section of this channel, webinars are segregated into various folders on topics like orthopedics, neurology, sports and fitness, pediatrics, cardiopulmonary, women's health, research, cancer rehab, etc. for easy access. The social media links will be shared in the chat shortly. Here, I would like to ask Dr. Nikki to please go forward and moderate the session. Thank you.
Thanks a lot, Dr. Das, for your kind words. Thanks a lot. Now we'll be starting the webinar. Good evening, everyone. Myself, Dr. Nikki Tyagi, convener IUP Noida. And on behalf of my team, I extend a very warm welcome to all of you. I'm also grateful to IAPWC Noida team for their constant support in organizing this event. So the topic for today's webinar is Bppv and its physiotherapeutic approach. I'd like to introduce our speakers for today who will be sharing their expertise. Our first speaker is Dr. Amit Tyagi, sir. Dr. Amit is MSc and MCH Head and Neck Surgical Oncology with an experience of 10 years. Sir is currently working as Assistant Professor in Delhi State Cancer Institute. Now, our second speaker is Dr. Amit Verma, sir. Sir is BPT and has done Masters in Physiotherapy, Masters Physiotherapy in Sports from GNDU Amritsar and currently working at Arogya Super Speciality Hospital, Hapur. Sir has got 2 international publications on vestibular rehab. So let's start a productive and engaging session. Thank you. Thanks a lot, everyone. And please feel free to ask questions in the chat throughout the session. Thank you so much. Can we start the session now? Over to Dr. Amit Tyagi, sir.
Thank you, Dr. Rekhi, and thanks to the very much for the all Indian Association of Physiotherapists Noida team. So here we will going forward for the topic of the BPPV, which you have given me to it. But directly going to the benign paroxysmal positional vertigo, it would be great if we start our session from the vertigo. So that's why I have kept my slide or the presentation in form of a vertigo. And as we go proceed in the topic, we'll get to know more how we approach a patient of a BPPV. Is that be okay? I hope so. So I'm sharing my screen. Is my screen visible?
Yeah. Screen is visible, sir. You can go ahead.
Okay. So thank you, Dr. Nikki Tyagi, for the nice introduction. Something's wrong. Yeah. Now is the slide moving?
Yeah, so it's fine. You can carry on.
So as we see that whenever there is a vertigo is present, it's not is just not because it is arising from the vestibular apparatus or from the central causes. Basically, it's a coordination between the different areas of the body. When we talk of eyes, vestibular apparatus, that is the ear and all, in the cerebellum, the joint tendons, basically the proprioceptive receptors coming from the joints, muscles, and the bones, and the eyes, and the spinal cord. The spinal cord, there are different spinothalamic tract, lateral, anterior, and the posterior spinal. All these comprehend in the brain higher center, and that's how we get an equilibrium position in our body, so that our body will become stable and there will be no giddiness or haziness in our eyes or anything, or a tendency to fall which is present over there. So when we get an impulse from the eyes, vestibular proprioception, I told they get comprehend in the higher center, and then this all the spinothalamic tract from the higher center, they keep a balance of the body. So what is dizziness? Dizziness is basically a disturbed or impaired spatial orientation without a sensation of self or environment. So the generic other terms which is used for the dizziness are the giddiness, lightheadedness, faintness, vertigo, fogginess, imbalance, ataxia, and unsteadiness. It is the single most complaint among the patients, those who are older than 75 years, and it is the third most common complaint among the all outpatients in the OPD. So as per the American guidelines, the dizziness is further divided into whether it is the vertigo, feelings of the motion, where there is a tendency to sway, the patient may fall. Pre-syncope is something like before the patient go for a syncope, their attack, he is feeling there is a blank out or a vision block is there. That kind of feeling, which generally happens in the cases of orthostatic hypotension, which usually happens in case of hypertensive patients, those who are on the drugs of the antihypertensives or on the diuretics. Then another cause is a psychogenic, which is happening in case of depression, panic attack, and anxiety. And other is a whenever there is a mismatch, either because of the reflexes, either the patient doesn't have a limb or there is eye coordination is there or vestibular coordination is not. So we must know the gravity of the vertigo, whatever the prevalence is there. So it is the false sensation, as I told earlier, accounts for around the 54% cases of the dizziness. And vestibular vertigo generally affects more than 5% of the adults in 1 year. This is the US data. We come to our Indian data. And majority of the cases of vertigo is peripheral, around 80%. If we talk around 80%, means 4 out of 5 cases are belongs to the peripheral and only 20% belongs to the center. So the main cause of vertigo is a peripheral vertigo. So we be focusing more on the peripheral. So as per our Indian studies, what is the prevalence in our country? There are around 5% of the patient visiting the general practitioner, almost around double of it going to the otolaryngologist, and there is lifetime prevalence. Anyone can get vertigo of around 30%, and this incidence of vertigo keeps on increasing as our age advances. So generally the prevalence, as I told, around 80% of the cases belongs to the peripheral vertigo. And out of that peripheral, majority of the cases belong to the benign paroxysmal positional vertigo, which is the today's topic. So other causes are also there, like second most preferred if you go is the Meniere's disease. Basically, it's a endolymphatic hydrops. There is a swelling happens in the endolymph inside the inner ear, and it presented by a generally a triad, which we said of tinnitus, which is a ringing sensation in the ear, vertigo, and the sensory neural deafness. Then the vestibular neuritis, it's an inflammation. Inflammation either because of virus or the bacteria. Patient is having a severe disequilibrium and tendency to fall. Patient cannot stand in this kind of condition. So we have to give a vestibular sedatives, we have to give an antibiotics, we have to give an antivirals over there to come out of this situation. Then labyrinthitis, how we differentiate vestibular neuritis and the labyrinthitis. In labyrinthitis, along with disequilibrium, you have a deafness. But in neuritis, you don't have a deafness. Whenever the term itis is there, it is suggestive of inflammation. So when we talk of a labyrinthitis, there is a deafness plus disequilibrium. When we talk of vestibular neuritis, it is inflammation of the cochlear nerve, but there is deafness is not there, but definitely disequilibrium is present. So generally, when we talk of a peripheral vertigo or central vertigo, so we have to differentiate whether it's peripheral or central. In peripheral, we have majority of the times Bppv, and the other causes, as I explained earlier, central we come to it. So what is the impact? What will be the happening to the patient? Generally, the quality of life will be very much in trouble for the patient. There is a physical disorder with a low morbidity, as people say it. But in generally, how the morbidity happen to a patient? It happens in the terms of loss of confidence, reduced self-esteem, and feeling of vulnerability, and the fears of the fall, which is present. it happens to that extent that sometimes the patient has to quit, change, or modify their jobs due to their symptoms. So patient who is engaged in like a driver activity or those who run in having machinery, they are not able to do it. They might have to change their. It's very difficult for that patient, and they found themselves handicapped. So this handicap index almost goes to 50% in the some of the cases where the vertigo is not controlled. So what are the differential diagnoses as we talk of? So before we going for the differential diagnosis, as I told, there are two things, whether it's peripheral causes or the central causes. But there is a one more cause, which is generally overlooked. This is the cervical spondylosis. You people know it better than me, the cervical spondylosis. What will happen? There is a straightening of spine will happen. There is extensive osteophyte formation will be there. And there is a decreased blood flow. The moment the patient try to give a movement to the neck, either in the yes or no position or atlanto-occipital, atlanto-axial joint, there will be decreased blood flow from the vertebral or the vertebro-basilar artery. And the patient is having a giddiness because there is a hypoxia over there. And that's how it precipitates. So around 50% of the cases will have vertigo if the patient is having cervical spinal degenerative cervical myelopathy. And in out of those patients, in on the radiological, those who have osteophyte formation or cervical spondylosis, this osteophyte formation is too much. Around almost similar 50% of the patient, they will complain of vertigo as one of their symptoms. So this is the condition which is generally overlooked, and you might have seen our elderly patient. They say this patient को तो cervical है. So its cervical is a rare condition for vertigo. But whenever it's present, definitely vertigo is one of the features. But the only way to get it, ask for a neck movement of the patient. If there is on the neck movement, the patient is complaining of giddiness, there may be there. So you ask for an X-ray. X-ray will be there. You will see osteophyte formation and the straightening of the cervical spine, cervical curve. So that's how you get an idea of it, and accordingly, how to proceed. You give a cervical collar, or give you a rehabilitation exercise, or ask a orthopedician help. That area I know better than me. So to find how we'll go for a proceed, whether it's a cause of central or peripheral vertigo. So this is a diagnostic algorithm. Whenever the patient is present to you in OPD, generally the patient comes to you with a dizziness or vertigo. They won't come to you with it as a case of Bppv. That's why I have thought, okay, I will take this class session as a vertigo onwards. So whenever a patient coming to you, the doctor साहब मुझे सिर्फ dizziness हो रहा है, then there is a gait instability is there, disequilibrium, or either patient is having lightheadedness. So we have to rule out the metabolic causes, vascular causes. There might be hypoglycemia, anemia because of low hemoglobin, dysarrhythmias because of derangement in the electrical activity of the heart, MI, hypovolemia, vasovagal, sepsis, and drug effects. Coming to the vertigo, what is the peripheral and the central? So in both the cases, how they present it up. So the severity of peripheral vertigo is very severe compared to the central. Onset is sudden, the more patient will come, so it will tell you the duration will be seconds to minute, and positional. Whenever there's a change in position, it will be present, not in case of central, and they get fatigue. Whenever there's a visual fixation is there, over the time period, they will get fatigue. You won't be able to elicit the nystagmus in that case. Then postural instability won't be much in that. And hearing loss, it can be present, but the neurological symptoms will be less. And associated nystagmus will be present, but the direction of the nystagmus will be horizontal and vertical. I'm not going much into the details of the horizontal and verticals. In general, I will tell you there are something called Alexander's law and Eval's law. There are Alexander's law, there are three types of nystagmus, which is grade 1, grade 2, and grade 3. So nystagmus, we tell whenever we have a case presentation towards the fast component. So nystagmus, it has two components. One is saccades, one is pursuit. Saccades are called the fast components and pursuit are called the slow components. When you look at the side of the fast component, there will be nystagmus, that is the grade 1. When you look at the straight, again you have a nystagmus also in the fast case, and the straight case is grade 2. When the nystagmus, if you're looking at even the slow side of the face, these things you will get over a period of time when you start seeing the patients more and more over there. So the first priority, whenever a patient is coming to it, we have to differentiate whether it's peripheral or central. So the one thing which will help you, the history of the patient. Patient is coming, sir, I came to you that I'm having, when I roll my head in the bed, I get a vertigo, or I'm standing, not able to, there's a tendency to fall over there. So when you look at the nystagmus, whether it's get fatigue or not fatigue. If it's get fatigue, the chance may be peripheral, and in peripheral, you go Bppv as the first cause. If it's not fatigable, go to the central one. Central one, we will come to it later. What are the most common causes of it? So one thing you will ask the first thing over the patient is whether you have any neurological symptom. Because in peripheral vertigo, neurological symptoms are not there. So if the neurological symptoms is there, think of a central cause. So generally, what are the causes which you get as a BPPV? I told vestibular neuritis, Meniere's disease. I told autosclerosis, one of the condition where your middle ear steps, it get fixed over the oval window over there. So the pliability of the steps moving over the oval window becomes stiffness. So that's why you get a vertigo. What is the vestibular migraine? When we come to it, vestibular migraine, if we look at the term, there is a vestibular plus migraine. So the patient is having headache plus disbalance. If both are component are there, then you think if it turns out it may be a cause of a vestibular migraine. Coming to the cerebrovascular disease, at the name itself says cerebrovascular. The patient may be having of a weakness of the one half of the body, other may be having faciobrachial monoplegia, maybe having hemiparesis, maybe having quadriplegia. That may be one of the reasons, or maybe vertebrovascular syndrome or ischemic disease. The other cause of the central causes are the CP angle tumors or posterior fossa angle tumors. So when you look into the CP angle, the most common cause is the vestibular schwannoma or acoustic neuroma, what we call it as. So to look into that, you have to ask for the MRI of the patient or the CT scan of the patient. So the other cause, as I told earlier, for the dizziness are the psychiatric medications induced or the orthostatic hypertension. So basically, when we look into the patient is coming to as a dizziness over there, you ask for the history, how it is presenting. Patient will you give a history that the doctor, when I came, there is something happened, whether I swaying or not swaying is the risk. Then the other thing which you look into the matter is the positive organ would be when there is a mnemonic called ABCD2 and standing, it is given down. We have to check the age. Elderly patients are having most common cause of vertigo are present. Blood pressure, where the patient is taking blood pressure, then ask for a history of medication. Are you taking your medications properly? If you're taking too much drug, definitely there is sudden drop of BP, which is called orthostatic hypertension. It will postural hypertension, common in the antihypertensive patients. Then ask for the other clinical features over there, whether patient is diabetic, because those patient gets a neuropathy, they'll not be able to get their sensation. There's a tendency to fall also present. And the duration of the symptom. Duration will give you a hint whether it's a sudden precipitate or a long stand. Generally, peripheral causes will give you a sudden presentation. When we talk of a central causes, they will present over a period of time. Their gradual presentation is there. So other examination which you ask for a vascular ocular reflex or the hit head impulse test and the hits. These are the different methods we'll go further. So how do we differentiate whether it's a central cause or peripheral? Because any patient will not come to you with a diagnosis of BPPV. You have to find whether it's BPPV or it may be something else. So you have to check for a central cause, look for the head impulse. When you give a head thrust over there, the second, the first component, they will try to change, remains on the same position in case of central. But when we talk about peripheral, because sudden movement will be there, the impulse is going from the vestibular ocular system over there, and eyes are not able to fix. When they go to the extreme, they try to fix on the particular. If you look at this here. So in that center, the nystagmus direction will keep on changing. But as I told peripheral, once the ocular reflexes is fixed, your nystagmus intensity will reduce. But if you provoked it, it will happen again. And it's a single direction nystagmus. Generally, these are horizontal because most commonly what we are happening is in the posterior canal. So these are horizontal, but in case of central, these are generally vertical can be present. And then the skew deviation. Skew deviation generally comes from because whenever the impulse from the retina goes to the higher center, then they come back and they comes to the ocular muscles. So you have to check three nerves, 3, 4, and 6. We have LR6SO4, that is the mnemonic for the lateral sixth nerve and superior oblique for the fourth, and rest all by the third. So when we see the patient, muscle image is formed on the retina, then goes to the higher center, that comes down, and then how the muscles of your ocular, they work upon, they fix it. But this happens from the higher center, not from the peripheral. So the skew test will be absent in case of peripheral, but it will be present. So skew deviation you will see in central. So the moment you say there is an incoordination between a patient in the eyes, squint you call it. It may be paralytic, non-paralytic dependent. So it's because of a central cause or either from a local cause, either because of eyes, muscle, something issue is there, either some palsy of nerve or from the central cause, but not from the peripheral. So this is the basic thing, how you will differentiate between central and peripheral. If central, management will be different. If peripheral, then we have to find out what are the other etiology for that. So the most common which comes is now is our topic is the BPPV. When we say it's a BPPV, So if we look at the first three questions, do you feel dizzy mostly when your head is moved? Patient will say yes. Do you have spinning or whirling sensations surrounding yourself? Or does the dizziness last? Because these are short moment duration. They don't last longer. Only central causes last longer. So it will give you a certain idea, okay, it is PPPV patient. Then ask other things, whether you're getting is sitting down, lying down. So it will tell you different canal, whether anterior, posterior, or the horizontal canal is present. Then whether going on the right side and the left side, it will give you an idea whether the right side of the peripheral or vertebral apparatus is an issue or the left side is an issue. And then the duration of that. So basically this will tell you what, so how you get whether it's a BPPV is there. Then you get for the Dix-Hallpike maneuver. I think our next speaker, Dr. Amit Verma, is going to explain more about this, so I'm not going to detail. But this is the maneuver when you ask, keeping a patient at the 45-degree, bringing it suddenly back at the couch or the back end, putting it down, look for the nystagmus, turning it up. The nystagmus we will see there's most commonly PPPV. When you do the Dix-Hallpike maneuver and we do the rollover test, we try to exactly what is happening in PPP, the vertigo. There is something called calcium carbonate crystals, which are called the otoconia, which are present in the semicircular canals, which has a ampulated end, which has a cupula. Over there, when these crystals come out of that cupula, so they comes in the canal and they irritate the nerves over there. That's how the vertigo sensation. So there are two mechanisms that's happening. One is canalolithiasis, one is cupulolithiasis. I'm not going into details because for that we had to go for Evol's law. And so that is more of a physiological, rather come over this topic on the practical aspects. So when we look at the Dix-Hallpike maneuver, by this time we got to know it is a posterior canal BPPV, and for that we have to do rehabilitation exercises. I think that is going to come in the next topic. So another head impulse test is how we get it. As I told earlier, it's a vestibulo-ocular reflex is present or not. This will tell you because this reflex is coming from the vestibular nerve, from the ocular going and coming back. So if something is wrong with the nerve, this reflex won't be elicited. So if this reflex is present, it means there is an issue with the peripheral, not a central cause. So there are three things which you have: head impulse test, nystagmus, and the test of skewedness. These three tests will tell you whether it's a cause is central or peripheral. And accordingly, proceed for your case, whether this is going to be peripheral. And if it's peripheral, most common cause, as we know, of BPPV, you can go ahead for the maneuver exercises. If not trained, then you can ask your, take your ENT colleagues' help to give a pharmacotherapy. So this is a tool which is present on the online. You can take a link from there. So this is a, they have given a graph of some set of questionnaires. When you put it into it, they will give you a probable diagnosis. Don't take it as a sacrosanct, but they will give you a probable diagnosis that will help you in treating your patients well. So imaging test, how we go for it. As I told, if it's a cervicogenic, you ask for a CT scans or an X-ray, and we look for MRI scans. If you find it a cervical central cause, it may be posterior fossa abnormalities. There may be a temporal bone abnormalities will be there. For that, you will ask for a CT scan. And MR angiography, if there is a vertebral basilar insufficiency, then you ask for angiography. Then definitely ultrasound, we can ask for first aid to look for the spasm and all that will help you out, because if the ultrasound is no, most probably it's the spasm it is going to. Then electroneurobiography to look for the ocular movements. But generally when we ask is the MRI and the CT, we look for any structural abnormality, maybe a tumor may be present over there, or maybe some inflammation like skull-based osteomyelitis, all this may be present. So coming to the management, how are we going to manage it? So it's a comprehensive management. One treatment will not fit all. So initially, but then any patient which is coming to you, first, the day one coming, first we don't know whether it's a central or peripheral. First differentiate whether it's central or peripheral. If central, treat different way, ask for investigation if something is found. And if it's curable, surgically salvageable, send it to a surgeon. And if it's coming to peripheral thing, the first thing patient is coming, you cannot put any patient coming to a peripheral is that, okay, I will do a directly a BPPV on you. You give a form of a pharmacotherapy. Generally, the most common drug is used is the beta histine, which go by the name of a trade name by the Vertex. Generally, I have seen people giving the dose of 8 mg, 16 mg OD. This dose not going to work. The standard dose is 16 mg thrice daily. It's total 48 mg has to be good. And once you give, you don't have to continue this stuff for longer duration because there will be vestibular suppressions will be there. So you have to start retraining the patient in the vestibular rehabilitation exercise or the band or of exercises, which is in the next topic probably. So after all these are done, then you ask for a patient of psychotherapy if it's a psychogenic cause, and if it's a surgical salvageable case, we go for a surgical. So when we give a pharmacotherapy, what is the management role? We give vestibular suppressants, either in form of antihistaminics like beta histine, which is antihistaminics, or dopamine agonist, serotonin receptor. So, and the ideal vertigo drug should be, it has effect on cochlear and cerebral fluid. Basically, they increase microcirculation and does not interfere with the vestibulocochlear mechanism. Regular vestibular nuclear firing offers symptomatic and prophylactic therapy, does not cause drowsiness because already patient is having giddiness and vertigo. And if you give a drug which causes more drowsiness, it's difficult for the patient. And should have a safety and tolerability, and should have antioxidant properties to combat the inflammation which is present. So the most commonly vestibular sedatives, I have seen people, those who are giving, okay, give a diazepam, prochlorperazole, you don't have to give because these are sedative. When you have a neuritis or severe inflammation, that time you give to take rest of the body for 2 to 3 days. But if you keep on continuing, your rehabilitation mechanism goes off. So these are a very careful drugs. It's like a seesaw. If you put one pedal up, the other will go down. So they don't have to use, because if you use it, the issue is reduction in your symptoms will come price of a vestibular function. So here your vestibular retraining or rehabilitation therapy comes into view. So it is a like of a multimodality approach rather going a single modality. So vestibular rehabilitation therapy, this is again going to coming in the next topic. So that we have to start as soon as possible over there. So that is all from my side. So basically the take home message is a patient is not coming you with a diagnosis of BPPV. It be coming with you a diagnosis of a dizziness. Then try to find out whether it is what vertigo is diagnosed. Then you see it's central or peripheral. If it's central, peripheral, how will you go? Check for the hints. Head impulse test, nystagmus, and test for skew. If these are present, differentiate accordingly whether it's peripheral and central. Central, ask for investigation, CT or MRI, or look for the vestibular like cerebellar disease, which is the common. So you, by clinical examination, you can ask for a dyssynergia, asynergia, then dyshedral kinesia, Lomborg's grade, all those will be present over there. So clinically, you can get it from there, or like loss of pain and touch sensations that you will all get from there. Coming to the peripheral cause, most common is the BPPV, but to get a BPP, you do a Dix-Hallpike. When you on the Dix-Hallpikes, you elicit, okay, there is an nystagmus, then you think of a BPPV and proceed accordingly. And other causes are the miniasis, autosclerosis. For that, you ask for a pure tone audiometry, and if there is a sensorineural deafness or something, refer it to your ENT colleague and treat accordingly. But when you give a pharmacotherapy, you have to add on do a vestibular rehabilitation exercise. That is the most important part. I have seen my colleagues also, those that they just treat it by the drugs, but they don't start the vestibular rehabilitation exercise. But if you don't give a combined modality treatment, patient is not going to benefit and it's not going to last long. It will recover back. So the patient has to retrain in the vestibular rehabilitation exercises. That's all from my end. Thank you. If any question, I'm happy to answer.
Thanks a lot, sir. Thank you so much for this lot of information. I think this has cleared a lot of doubts which we were having earlier. Now over to Dr. Amit Verma, sir.
Hello, am I audible?
Yes, sir, you are audible. So you can start now. Thank you.
Okay. सर ने बहुत कुछ बता दिया है
Not much. I hope you will take the talk to the next level. I'm looking forward to it.
Dr. Amit Verma, sir, you can start now.
Yeah, I'm sharing the screen. Let me do. से बनता है। बोनी कैविटी इज मेड अप ऑफ पेट्रस पार्ट ऑफ द टेम्पोरल बोन, और जो मेम्ब्रेनस होता है वो होता है सेक्स, और उसमें अर्टिकल आता है, सेक्यूल आता है, और सेमी सर्कल कैनाल आता है। अब इनमें जो ओटोकोनियाज होते हैं, मींस ओटोकोनियाज आर क्या, तो नाउ सेमी सर्कल कैनाल में फ्लूड होता है, जो कि एंडोलिप फ्लूड होता है। वो हमारा पोजीशन चेंज करने से उस एंडोलिम्फ फ्लूइड पोजीशन चेंज होती है, और उससे एम्पुला डेविएट होता है, और उस एम्पुला के डिफ्लेक्शन से हमको पोजीशन का एहसास होता है। मींस ब्रेन विल गेट नॉलेज अबाउट द पोजीशन ऑफ द बॉडी इन द स्पेस, द एनवायरनमेंट। तो जो सेमी सर्कल कैनाल होता है, उसके फ्लूइड से हमारा एंटीरियर, पोस्टीरियर और हॉरिजॉन्टल एक्सेस जो होते हैं, उनके बारे में हमें इंफॉर्मेशन मिलती है, ब्रेन को इंफॉर्मेशन मिलती है। लेकिन जो ओटोलिथ ऑर्गन होता है, मींस आर्टिकल और जो सिक्यूल होता है, वो हमारा लीनियर मोशन बताता है, मींस आगे पीछे जाना और साइडवेज जाना, हॉरिजॉन्टल और फ्रंट और बैक। ओके। और ओटोलिथ में ऑर्गन में हमारा ओटोकोनियास होते हैं, और ओटोकोनिया एक कैल्शियम क्रिस्टल्स होते हैं, जो कि सेक्यूल और आर्टिकल में होते हैं। वो वहीं से हमें लीनियर मोशन का एहसास कराते हैं। लेकिन अगर वो वहां से हटके सेमी सर्कल कैनाल में आ जाएं, और उसके कॉजेस क्या हैं, वो उसमें आ जाए, तो एंडोलिम्फ का जो मूवमेंट है, एंडोलिम्फ का मूवमेंट को डिफ्लेक्ट कर देते हैं, जिसकी वजह से हमें रॉन्ग परसेप्शन ऑफ द स्पेस का एहसास होता है, और इसलिए हमको वर्टाइगो का एहसास होता है। मींस पोजीशन चेंज करने से ही वो वर्टाइगो आएगा, वरना नाउ जब ओटोलिथ ने ओटोकोनिया कैसे हमको सेंसरी परसेप्शन कराते हैं, और सेंट्रली कैसे इंफॉर्मेशन मोटर आउटपुट में बदलती है, उसका थोड़ा सा एक एस्पेक्ट है। एक शॉर्ट में उसको कहते हैं वेस्टिबुलर ओकुलर रिफ्लेक्स। उसके थ्रू ये सब इंफॉर्मेशन हमें मिलती है, और उसी की वजह से वर्टाइगो का एहसास होता है। मींस सेंसरी कंपोनेंट हो गया सेमी सर्कल कैनाल, ओटोलिथ जो मैंने अभी बताया। इसमें यहाँ से जो एम्पुला से जो इंफॉर्मेशन जाती है, वो हमारा क्रेनियल नर्व्स के थ्रू जाती है, जिसमें कि ऑक्लोमोटर नर्व, ट्रॉक्लिया और एब्डुसेन है मेनली। और ये नर्व्स आउटपुट में, मोटर आउटपुट जो है इनका, वो होता है ऑकुलर, एक्स्ट्रा ऑकुलर मसल्स जो है। इसमें रेक्टस आती हैं, मींस रेक्टस में मीडियल रेक्टस भी आती है, लैटरल भी आती है, सुपीरियर, इंफीरियर एंड इवन ऑब्लिक्स भी। तो इन्हीं इन्हीं रेक्टस मसल के मिस फायरिंग होने की वजह से हमको निस्टैगमस मिलता है। व्हेन वी गो फॉर द डिक्सोल्फिक टेस्ट और सुपाइन रोल टेस्ट और एंड बो एंड लीन टेस्ट, ये जो भी है टेस्ट, उनसे जो हमें निस्टैगमस मिलता है, वो इस मोटर आउटपुट के मिस फायरिंग की वजह से मिलता है। Now we are coming for the Dix-Hallpike test. Dix-Hallpike test में once we have diagnosed that this vertigo is not from the central, it's a peripheral one, और पेरिफेरल में भी ये बिनाइन पैरोक्सिनल पोजिशनल वर्टाइगो से है, क्योंकि ये वर्टाइगो लेस देन ए मिनट में आ रहा है, लेस देन ए मिनट तक रह रहा है, और पोजीशन चेंज से ये प्रीडिस्पोज हो रहा है। मेन ये एक बहुत कॉमन सा सिम्टम है, या कॉमन सा सिम्टम है जिससे हम टेस्ट के लिए जा सकते हैं, और ये गोल्ड स्टैंडर्ड टेस्ट है डिस्क हॉलपिक मैन्यूअर। इसमें पोजीशन पेशेंट को हम बैठा के रखते हैं, पैर फैला के टेबल पर बैठाया, उसके बाद हेड को टर्न करा 45 डिग्री, एंड देन make him to lie down with head extended up to 20 degrees approximately, and then we should observe the eye. Is there any sense of feel of nystagmus, or we can see whether we can able to see the nystagmus or not. In this we can get nystagmus either lateral, either superior, or inferior also, and only torsion also we can get based on the canal which will be the involved. So vertical nystagmus is basically the upbeat and the downbeat one, which is associated with the vertical canal. It can be associated with the torsion or the non-torsion without torsion. While the horizontal is basically come from the horizontal canal and it may be the geotropic or apogeotropic. Geotropic is toward the ground, and apogeotropic, but nystagmus is toward the ceiling. Once we go for the roll test, when we go for roll test, the our both eyes will be in the same vertical plane, and then we can see it, the movement of the eye is in the toward the ground or toward the ceiling. And basically the I have a patient video, like I can show also. This is one of the kind of lateral nystagmus. Is everyone able to appreciate this? Will I play once more? Dr. Nikki, will I play once more?
Yeah, so you can play it once again.
This, you can see it's a lateral nystagmus. It is more on the geotropic one. It is a horizontal. Slow component in the downward, and then corrective is in the upward. I have many such videos which can describe which can by which we can identify the side of the ear which is involved, either right or left. Am I audible? Is there any lag due to internet connection?
Yes, so there is in between there, your voice is breaking, but now it's fine. You can continue.
Hello. Now when we come for the management of this BPPV, when we go for the management for the BPPV, then there are various CRPs are there. Canalite repositioning procedures. Is it fine, Nikki? Dr. Nikki, is it fine?
Yeah, sir. You can carry on, please.
Okay. Based on the canal involved, the maneuvers will change. Like for posterior canal involvement, mostly the maneuvers used is the Appley's maneuver and liberatory maneuvers. And for the lateral canal, there is a Lampard maneuver and the Pony maneuver. While for anterior, there is a deep head hanging and vibration is basically for the cupulolithiasis. There is when we go for the upward. Mm, each canal has a long arm and a short arm. So the maneuver for especially for the posterior canal, the maneuver will be changed for the long arm and the short arm. Basically, for the long arm, Appley's maneuver will be used, and the liberatory is used for the short arm. Apart from repositioning procedures, there are many cases which have escaped the sense of vertigo is not there after the repositioning procedure, but a sense of dizziness is still there. For the sense of dizziness which the patient have, then we should go for the strengthening of the VOR. Means we should strengthen all vestibular ocular reflex, which has the vestibular aspect and the central aspect and even the vestibular aspect. So a complete management should be done by vestibular exercises, which comprises the gaze stability also, proprioceptive strengthening, means proprioceptive retraining, I can say proprioceptive retraining, and gaze stability, and other than this is the postural stability also. So all phobia to release the phobia of dizziness or phobia of dizziness in cases of vestibular migraine and the post residual dizziness. Now when we first I can show the how to do Appley's maneuver. This is a pic for Appley's maneuver of the right ear affected. So we should turn the head 45 degree and then make the patient lie down with the head extended 20 degree, and then after that the third aspect, we should turn the head toward the left side and then roll over toward the left side and then make the patient to sit. By this we just carry out the otoconia, which are free floating in the semicircle canal to make them settle way back to the sacule. So if we know the orientations of the posterior canal and lateral canal at the specific angle where they are, so it is easy to do all these things. Like I have also one pic like this. So it's a ampulla, cupula. This is cupula under this ampulla, and this is the long arm. This is short arm, and we are giving the otoconia the way to settle in the article where from they are dislodged. Here he is rotating in this pic. There is rotating the head, and then it is extended. In second, it is now in third. This is rotated to the left side and then roll over and then making him sit. So the carryover of the otoconia from this stage like this, and then from second here, then third from here, and then fifth is it got dislodged from here. Now we are coming back to this thing. There are many more maneuvers are there, but it demands so much of time to show all the maneuvers. Now if we go for the one more thing we have left, the cupulolithiasis. Actually in cupulolithiasis, it is the cupula and the otoconia is got stuck in this cupula. It is got stuck in this cupula. Now until and unless we will shake it or do the maneuver in a harder way, we can't make this cupula to vibrate. If we vibrate it, then the otoconia will be dislodged from here, and it can be if this otoconia are stuck to this end from long arm side of the cupula, then it will be released on the long arm, and if these are stick on the short arm side of the cupula otoconia, then they will be dislodged in the short arm. In short arm, it will be go easily to the article, but after vibration we have to give one more place so that it can be easily go to the article, make way to go to the article. Now for vestibular exercises, whenever the once we have given the maneuver and the acute sense of vertigo has been overed, then the role of vestibular exercises, rehabilitation exercises will come. Any episode of vertigo or dizziness will give a stiff neck, stiff shoulders, because the body has to compensate for the dizziness or vertigo, uh, to make the body stable. So neck and neck muscle will be stiff. So we have to do those exercise which will give a gaze stability together with head movement, together with neck movement, will be more beneficial than a normal neck movement exercise. So X1 paradigm, like we have to stable the gaze at one point, and then move our head toward right or left side, and then do side bending or extension or flexion. Means we are making the eyes stable on one point, and then making the neck movement like rotation right and left, and then sideways, and then extension or flexion. Eyes we have to make the patient to posture change with eyes closed, so that the proprioceptive senses from the muscles will be carried out, will be strengthened. I can say will be strengthened. So with eyes closed, we have to make the patient uh, lie side lie down, and then sit, side lying down to the right side, to the left side, and then make him sit. We can make roll over to the right side, roll over to the left side on the bed, on the couch or bed, which will strengthen the proprioceptive sense, and I can say overall vestibulo-ocular reflex. Other than this are the yoga. Means yoga exercises are also very beneficial for to strengthen the core, because all of the yoga asanas will be done by making a gaze stability first, and then we have to maintain that posture for a single breath, or for two breaths, which will together with the posture stability will give gaze stability also. So these yoga asanas are also very beneficial for to reduce the dizziness. Now this is all over. Branded head of exercises are those exercises like I have said. We have to make the patient sit right side, lie down right side, and then sitting position, then to the left side, rotate the head, and then come back to the sitting positions. But there are all these things there are much more than these simple things. We can do much. We can give much more than this if we have to get the time for all these things. So very much thank you, Nikki.
Thanks a lot, sir. Thank you so much for this valuable information. Now, thank you everyone for taking time to attend this webinar, and hope you found this session a very valuable one. Now, let me take there are some queries, sir. Can we just take them?
Okay.
I think it's already been done.
It for the sir.
Yeah, I think it's been done. Yes.
Please have a look at the chat section. The questions have been answered over there. by Dr. Tyagi. Thank you, Dr. Tyagi.
So there might be a question, what is the rehabilitation exercises? As the Dr. Amit Verma has told, there are different rehabilitations or maneuvers are present. If you go into the internet, there is a site by the Cipla of the Vertigo. Over there, they have given some few exercises which you can do either sitting, lying down position, standing, walking. So these exercises basically help in your eye-ear coordination and the body balance that we generally prescribe once the patient is on vestibular sedatives, and it has to be there, otherwise patient will not walk back again. Thank you.
Yes, sir.
If there are any more doubts, please put it in the chat section. Otherwise, we would close the session.
Thanks a lot again, everyone. I think every question has answered now. Or you can put up your questions in the chat section, and your questions will be answered shortly. Thank you so much.
There is one more question is there when we can shift the patient to exercises training. The moment the patient will say that these symptoms is the vertigo symptoms has reduced, or when you give a vestibular sedatives, the response from the higher central will be reduced. The patient will say, okay, my intensity has goes down and I'm feeling better. Then you ask a patient whether you are able to stand and do some exercise. The patient will tell you that I'm able to sit, I don't have any issue. At that time, you give a sitting exercise. If the patient is saying, okay, I'm having difficulty, so ask them to lie down and start a rehabilitation by looking at the different corners, asking them to change one side or the other. So all these are exercise will help in the brain coordination. So when the patient able to stand, then ask them to walk, and accordingly you proceed. What is the severity of the exercise or the grading of exercise you can tell to a patient. There is a question, what is the management Laplace and Lambert differentiated? I think Dr. Amit Verma is able to answer it better.
Yeah, actually Laplace is mostly given for the posterior canal involvement, and the Lampart is given for the lateral canal involvement. Okay, ma'am. Hope I have given. Sir, for you, for the medicine aspect.
So they have mentioned about the is looking for the medicine Vertin. Vertin is a basically beta histone. It will just simply increase the microcirculation. Whatever the spasm has happened over their area, it will increase the microcirculation. So generally we prescribe it for the 5 to 7 days. After that, even the patient is having vertigo, not able to, then we start putting on the vestibular sedative, which is generally we give a tablet of 201, which is a calcium channel blocker. Or there are other drugs which we give of, either we can give benzodiazepines or GABA derivatives. So depending on that. So once the patient we give, we must try to find out why the patient is having vertigo, whether the cause is peripheral and central. That's why I told that first thing we have to differentiate what is the basic cause of vertigo. Vertigo is basically a symptom. It has to be because of something. Some disease might be prevailing underneath. So we have to find what is the cause. Whether if you're thinking it's an inflammation, it will come up in your blood investigation where there is a counts are raised or something bacterial or viral neutrophils or the polymorphs are raised. That time that will give you some idea over there. Or you ask a patient whether he had any history of upper respiratory tract infection. That way you can segregate your patient and give a treatment according to the patients.
Thank you, sir. Thanks a lot. I think we'll take the other questions and they'll be answered soon in the chat box. Thank you so much, everyone.
There is a question of like vestibular.
Yes, sir.
For vestibular exercises, there is no limit. Individual, every patient has a different way. So as we say, every patient behave differently. So every patient have a different adaptability process. So if the patient able to adapt fast, you can taper it down. If not, continue the exercise as much as it required.
Thank you, sir. Thank you. Thank you, sir. Thanks a lot.
Thank you.
Thank you, ma'am.
Thank you, everyone. Thank you.
Thank you, ma'am.
Thank you all for joining the session.
Thank you.